السلام عليكم ورحمة الله وبركاته جميعا. إدارة الشؤون الأكاديمية وتدريب صحة الطائف ترحب بالجميع. طبعا اليوم ندوتنا بمزامنة مع الأسبوع العالمي للتوعية بالمضادات الحيوية. طبعا عنوان الندوة اليوم مستجدات مقاومة المضاد الحيوي، طبعا هي بالتعاون مع إدارة الرعاية الصيدلانية بصحة المدينة. لقاءنا اليوم بقيادة الدكتور رائف أبو العز، هو استشاري صيدلي عناية حرجة، رئيس قسم الصيدليه الكلينيكيه في مستشفى الحرس الوطني بالمدينه المنوره. دكتور رائف تفضل، المايك عندك.
طيب، السلام عليكم ورحمه الله وبركاته. السلام عليكم.
وعليكم السلام ورحمه الله وبركاته. دكتور رائف
مكتوب host disabled participation screen sharing.
هي تفضل.
طيب
تفضل يا دكتور. دكتور رائف المايك يا دكتور، المايك. شغل المايك يا دكتور. هي تفضل. واضح.
السلام عليكم ورحمه الله وبركاته. معكم رائف ابو العز، صيدلي كلينيكي كلينيكال سوبرفايزر في مستشفى الامير محمد بن عبد العزيز. تزامنا مع اسبوع التوعيه بالمضادات الحيويه، ان شاء الله حنبتدي محاضرتنا. I'll talk English, okay? طيب، المحاضرة my lecture will be updating the management of Carbapenem resistant Enterobacteriaceae. There is a very nice report about antibiotic resistant threat in the United States. Usually this report came every 5 to 6 years, and they discuss the threat of a new antibiotics, which everyone needs to take care of it. If you see here, the Carbapenem resistant Enterobacteriaceae, CRE, they consider it as urgent. They have concerning, serious, and urgent. Why they consider it urgent? Because there is a lot of infection, more than 1,000 deaths, and it costs more than $130 million for treatment per year. By the end of this lecture, we'll be able to describe the epidemiology of Carbapenem resistant Enterobacteriaceae, CRE, know the importance of prevention strategies, know the current treatment option for CRE and their pharmacological limitation, and understand the role of combination therapy for CRE infection. First, let us start with what is Enterobacteriaceae. Enterobacteriaceae is a kind of bacteria that found normally in our gut. It has E. coli, Klebsiella, Enterobacter, and it is more than 70 genera. What is the CDC definition of CRE? CRE is called for any bacteria if this bacteria is resistant to imipenem, meropenem, doropenem, or ertapenem, one of them. And if it is resistant to the following third-generation cephalosporins: ceftriaxone, cefotaxime, and ceftazidime. What is the resistant species? Mostly Klebsiella. That's why they call it Klebsiella pneumonia CRE resistant. Also, carbapenemase reproduction have been reported in Citrobacter, Proteus, Serratia, so many bacteria. And why this, we're gonna see later. So what it can cause? It can cause a lot of serious bacteria, including bacteremia, hospital-acquired pneumonia, UTI, surgical site and wound infection, and hospital-acquired endocarditis. Simply, if you get admission to the hospital, specifically ICU, you are at risk of having this bacteria. What is the mechanism of resistance? There is a quote from Dr. Walid Al-Yafi. He is the chair of the ICU in Jeddah at King Abdulaziz Medical City. And he always said bacteria is smarter than human being. Why? Because every time human make antibiotics, the bacteria make resistance. So what's happened? Carbapenem has beta-lactam ring. The carbapenemase work in this ring, and then this lead to broken conjugation and inactivation of this bacteria. This beta-lactam ring is available in penicillin, cephalosporin, monobactam, aztreonam, and carbapenem. So if the bacteria has this carbapenemase, it will be resistant to all of them. So what is the other mechanism of resistance? Not only by carbapenemase, if it has extended spectrum beta-lactamase, plus it has a gene which will augment bacterial outer membrane permeability. So this bacteria will be resistant for the entrance of the antibiotics. How does it spread out? Through plasmid. What happened? The bacteria have a plasmid which contains the resistant mechanism. When it gets attached to another bacteria, this plasmid gets replicated and the other bacteria become more resistant. That's why we have more and more species that's considered as a CRE. What is the classification? It is not only one class. The first class is class A beta-lactamases. It required an active site of serine, do not hydrolyze carbapenems. The most famous one is Klebsiella pneumonia carbapenemase, KPC. And this one can be transmitted from one bacteria to another. The second class is class B, beta-lactamases, and known as metallo-beta-lactamases. Under MBL, there is more than one genera. New Delhi metallo-beta-lactamase, which is susceptible to colistin or tigacycline, and it hydrolyzes all beta-lactamase except aztreonam. The class D beta-lactamases, it's referred to OXA48. OXA48 is well known in Middle East and Africa. We'll see. So the first one is KPC. KPC is 12 variant. KPC is 12 variant. It is resistant or decreased susceptibility to all beta-lactamase antibiotics and most common in the United States. But this one has distributed to all over the world. MBL worldwide, and it was outside United States. Now it came back to United States. There is more than one species, as we said. The first one is New Delhi metallo-beta-lactamase, the most famous one. And we have Verona integron encoded metallo-beta-lactamase, VIM, and imipenemase metallo-beta-lactamase, IMP. It categorized by ability to hydrolyze carbapenem and beta-lactam ring, and resistant to mechanism-based inhibitors such as sulbactam. So if we use any antibiotic with sulbactam, it will be resistant to it. And it's susceptible to chelating agent. The OXA48, as we mentioned, it is most famous in North Africa and Middle East. It's found in the Acetobacter and it hydrolyzed penicillin and first generation cephalosporin. It has a weak activity against oxyimmunocephalosporin like ceftriaxone, cefuroxime, and cefotaxime. Epidemiology, as you can see, CRE is distributed all over the world. There was one study here where it collected the study all over the world in 2017. And there was one study in Saudi Arabia where it found that CRE considered as 15% of the total cases in those people. There was another study by Fawzia, where she go and collect all the studies from 2013 to 2018. And there was a total of 3,246 cases, reported cases. And most of them was Klebsiella pneumonia, KPC, then E. coli, then C species, and originosa. What is the risk factor? The first one is the use of carbapenems. The use of carbapenems and cephalosporin can definitely lead to CRE. Hospitalization is a risk factor, surgery is a risk factor, dialysis, mechanical ventilation, indwelling urinary catheter, and post-acute care and long-term care admission. So being in hospital is a risk factor for a CRE. Here, there was a nice study where it showed that if you don't use any carbapenem, then the risk factor is almost none. While if you increase this 1 to 3 antibiotic, then the risk factor will increase by 3 times. So this is make it very clear that the more of using of more antibiotics is a risk factor rather than cure for the patient. What medication are considered risk factor? If you use it, it will gonna increase the CRE, carbapenems, cephalosporin, fluoroquinolones, and vancomycin. Prevention. Prevention is most important than cure. The best way for prevention is infection control. We're gonna go in second slide through infection control. The first one is hand hygiene. This is not only for coronavirus, but also for all the bugs, including CRE. Contact precaution for colonized or infected patients. So there is a lot of debate regarding how many contact precautions we have to keep those people who have colonization. Some people said 7, some people said 14, but it is not clear. But any period from 7 to 14 days. Single patient room. And what if you don't have single patient room? Then bring all those patients with CRE and put them behind each other. Don't make them distribute them between other patients. Same as we are doing with corona patients right now. Minimize the use of catheters and endotracheal tubes. Antimicrobial stewardship, it is supposed to decrease the risk of infection because it will decrease the number of unneeded antibiotics, but it is not well studied yet. CRE screening may identify the patients who are colonized, and this may help to segregate those patients away from the other healthy patients. Experience of the other hospital regarding infection control. We have the State University of New York, where when they apply the infection control, the KPC decreased from 9.7 to 3.7. So by almost two-thirds. Sheba Medical Center, it decreased by 4.7-fold when they apply the restrict infection control from 6.93 to 1.8. University of Miami, those people, they were able to reach to 0, from 21% to 0 over 5-month period. There was a study where they apply in Israel infection control all over the nation. And what happened? The infection decreased from 666 per year to low of 4.8 per year per 100,000 patient days in acute care hospital. So infection control can really control the infection and stop the spreading of those bacteria. The treatment. We're gonna go over the treatment, but let us discuss some important concepts. Can we use carbapenem? The answer is yes or no. Yes, if you have a CRE which is resistant to ertapenem and susceptible to meropenem. By the way, ertapenem is less in the coverage than meropenem. Ertapenem does not cover Pseudomonas. If you have a carbapinimase, testing results are negative or is not available, then you can use meropenem. No, if you have a CRE which is resistant to ertapenem and meropenem, and there is a test which shows that the carbapinimase testing is positive. Shall we use 3 hours infusion or 30 minutes? Actually, there was a study in 2012 where they used so many techniques, and they found that when they use extended infusion plus other antibiotics, the failure rate was the lowest among the other study group. Now we're going to speak about the IDSA guidance. This was published just before 2 months ago. It is very nice guidance. It is not a guideline. It is a guidance, so it will guide you. Always depend in your antimicrobial biogram and use this one as a guidance for you. Those people who participate in this study, they came from very well reputable institution in the United States. So this is a very nice guidance for those people who want to treat CRE. In this guidance, they divide the treatment, either those patients who have UTI or non-UTI. So for UTI, they divide it, separate into uncomplicated or complicated. For non-UTI, they separate it into resistant to ertapenem, but susceptible to meropenem, resistant to ertapenem and meropenem, and the last one, if the bacteria has carbapinimase, it can produce the carbapinimase. Now we're going to speak about the first one, which is UTI, and the first section is uncomplicated one. So if you have uncomplicated cystitis, where CRE is resistant to ertapenem and susceptible to meropenem, and uncomplicated cystitis, which is resistant to both of them. If you have uncomplicated cystitis, then you can use Cipro or levofloxacin, trimethoprim, nitrofurantoin, or single dose aminoglycoside. So someone will ask, why you are using this while this bacteria has all this mechanism of resistance? What happened? Those antibiotics will be concentrated in the bladder, and it will be the concentration will be thousands of times of the MIC. So even if the bacteria is resistant, it will be sensitive to those antibacterial. If you have a CRE resistant to ertapenem and susceptible to meropenem, then you can use a standard infusion meropenem. We're not going to use prolonged infusion meropenem because we don't need it here. Because as we said, the meropenem will be concentrated in the bladder with 1,000 of time of the MIC. Now I'm going to speak about complicated or pyelonephritis. Again, we're going to have CRE, which is resistant to ertapenem and meropenem together. Thus, you're going to use ceftazidime with avibactam, meropenem and vabrobactam, imipenem, cilastatin, arilobactam, and cividirocol. Just focus on cividirocol because we're going to come to the same regimen in non-UTI, but without cividirocol, and I'll tell you why. The second one, if you have CRE which is resistant to ertapenem and susceptible to meropenem. So this one was resistant to both, but this one is susceptible to meropenem. And if you have carbapinimase testing which is negative or not available, then you just use extended infusion meropenem. What about fosfomycin? Fosfomycin, as you are aware, it is used for UTI for those resistant antibiotics. Actually, for uncomplicated cystitis, randomized controlled trials indicate that the oral fosfomycin is associated with higher clinical failure than nitrofurantoin for uncomplicated cystitis. So don't use it unless you have E. coli cystitis, because they found that fosfomycin is active against E. coli cystitis. For pyelonephritis, oral fosfomycin does not achieve adequate concentration in the renal parenchyma. And that's why you should not use it for pyelonephritis or complicated urinary tract infection. I remember one time, our team in our hospital, they tried to increase the dose of fosfomycin to reach the level, the higher level in the blood. But what happened? The patient developed severe diarrhea, and it was a failure. Now we're going to talk about non-UTI. Non-UTI, that means any other systemic infection outside urinary tract. We're going to talk about the resistant to ertapenem and susceptible to meropenem, and also we're going to speak about the resistant to ertapenem and meropenem. So the first case is resistant to ertapenem and susceptible to meropenem. Then you can just use extended infusion meropenem. But if you have a resistance to both of them, then you're gonna use the same regimen as we mentioned before. But cifidricol is not there. Why? Because they found that the mortality is increased when they use it for non-UTI patients. What about tigecycline? Can I use tigecycline? Tigecycline, the good things about tigecycline, achieve a rapid tissue distribution, but limited concentration in the blood and poor serum concentration. And they found that when they use the double dose, it is more effective for complicated intra-abdominal infection. That's why you can use tigecycline for intra-abdominal infection, and you have to use double dose. Don't use it for bloodstream infection, because there will gonna be a poor serum concentration, and you may get failure for the use of these antibiotics, specifically that it is bacteriostatic, not bactericidal. Now we're gonna come to the last section, is carbapinimase production is present. You have a bacteria which can produce the carbapinimase. We have KPC, where we're gonna use the same regimen as we said before. MBL, we're gonna use ceftaz with avibactam plus aztreonam, or we can use cifidricol as a monotherapy. For OXA48, For OXA48, you're going to use ceftazidime or avibactam. So as you can see, ceftazidime with avibactam is here and here and here. Plus MBL, if you use it for MBL, you have to use aztreonam. So this antibiotics till now, it's proven that it is a very good antibiotics, but please don't overuse it, otherwise you may get resistant to this antibiotics. Can we use polymyxin for the treatment of infection caused by CRE? Okay, so when they did the study, based on observation and randomized controlled trial, they found the mortality is increased. And there was a lot of nephrotoxicity with polymyxin-based regimen. So that's why polymyxin B and colistin should be avoided, should not be used. Any exception for this? Yes, there is exception for colistin only. Colistin, you have to make it as a last resort against CRE cystitis only, not against systemic infection. Polymyxin, you should not use it because it is not excreted renally, so don't use it. What about combination therapy? You know, everywhere people, they like to jump to combination. Is 1 plus 1 equal to 2 or 3 or minus? Actually, it is not clear. The observational data, but no randomized controlled trial, they did not find any additional benefit. And it increased the likelihood for antibiotic-associated adverse event. That's why it is not routinely recommended. In conclusion, CRE is an international health threat that requires urgent and aggressive action. There are a core action that will help to fight CRE. It is mostly infection control. Preventing infection and preventing the spread of resistance is more important than the treatment. We always focus in the treatment. We like to use very strong gun, but we don't like to wash our hand when we see the patient. We have to track the resistant bacteria. We have to have biogram for this. Otherwise, this will keep spreading through the hospital and we will not know about it. Improving the use of today's antibiotic. Don't use antibiotic for everyone unless there is a need. I saw several times since I am working in ICU, any patient who came, they just use vancomycin. And believe me, there is very, very few cases where I saw there was an MRSA. Most of the time, the patient does not need it. Penicillin is better than vancomycin for MSSA. It has less failure rate than vancomycin. By this, I'm going to come to the end of my lecture, and thank you for listening.
Thank you, Dr. Raif, for informative lecture. I would like to ask Dr. Hanan to moderate the lecture now, please. Dr. Hanan. Dr. Hanan, are you there?
السلام عليكم.
السلام عليكم.
يعطيك العافية دكتور رايف.
الله يعافيك يا دكتور.
هو الأسئلة إن شاء الله نستقبلها على Q&A، بس لسه إلى الآن ما وصلنا أي أسئلة.
طيب ماشي، أنا في انتظاركم إن شاء الله.
أستاذ طارق لو توضحوا بس إنه الأسئلة في الأيقونة Q&A.
اوكي، نحن حنستقبل الاسئله في خانه Q&A، واذا في اي سؤال توجهوه للدكتور رايف، ممكن تكتبوه برضه في خانه الشات مفتوح من بدايه الكورس، فتفضلوا نحن ننتظر اسئلتكم. طيب إلى الآن ما في أي سؤال، فما أدري إذا الدكتورة عندها أي نقاش تبغى تديره مع الدكتور رايف. تفضلي دكتور حنان.